to welcome and introduce Nathan Rodgers as the presenter of the Grand Rounds this morning. Many of you know Nathan. He started his career in undergraduate school in Boston, in Texas, in Houston, Texas. And he followed it. It was quite a surprise to me to learn about this, actually, that he obtained a master's degree in healthcare finance at the University of Texas as well. So thereafter, he continued medical school in Guadalajara, Mexico, and became a resident in pediatrics in New York. He came to us in 2013 as a fellow in pediatric cardiology and has been here since, pretty much with a short break. Many of you have known him as a fellow and then in the last 2 years as a faculty member. After his categorical fellowship in pediatric cardiology, Nathan obtained additional training in his area of interest and passion, which is heart failure, pulmonary hypertension, and transplantation at Texas Children's Hospital in Houston. And he really has a very special niche in the area of pulmonary hypertension, which is an area of need in the state. Probably the only pediatric cardiologist who had special training in pulmonary hypertension. Nathan has been active clinically, and his research interests are focused more and more toward pulmonary hypertension, although in the past he has shown activity and publications in the area of rare diseases in mucopolysaccharidosis, where he worked with Dr. Brownlin, but really transitioned recently his interest toward a stronger focus in heart failure, pediatric heart failure, and pulmonary hypertension. So we are very happy to have him here. He really fills a big gap in a specific, very specific area in pediatric and young adult cardiology, which are patients with congenital heart disease or acquired heart disease who develop pulmonary hypertension. And without further ado, I would like to welcome Nathan to teach us about pulmonary hypertension in pediatrics.
Thank you. Thank you, Julia. Okay, so today I wanted to talk to you a little bit about pediatric pulmonary hypertension, and I wanted to do this more as kind of a primer, since I know it's a pretty complex subject that not a whole lot of people come into contact with all that often, but being here in a quaternary referral center, I'm sure you see a lot more than most folks around the world. And so I hope to dispel some of the myths and kind of demystify pulmonary hypertension. I have no financial disclosures, and I would like to discuss a little bit about off-label use of some of the pulmonary vasodilators in pediatric patients, of which almost all of them are off-label, as other things in pediatrics. And some of those will include sildenafil, riociguat, epoprostenol, treprostinil, iloprost, selexipag, and macitentan. And so what I hope you guys would be able to take away from this is being able to define exactly what pulmonary hypertension is, and to know what normal hemodynamics are in children, and to recognize what the difference is between primary and secondary pulmonary hypertension. To know the pathophysiology of pulmonary hypertension, to be able to recognize what diagnostic modalities we use in pulmonary hypertension, and to identify the different therapies out there and what their pathophysiologies are. So just to review a little bit of normal physiology and development as it pertains to the pulmonary vasculature. This graph shows you here that pulmonary vascular resistance is quite high in utero. Up until the time of birth, the lungs are collapsed. As you remember, there's not much blood flow going out to the lungs, and as soon as babies are born, the pulmonary vascular resistance begins to drop as the lungs inflate and clear out all the fluid. And over the next couple of months, that pulmonary vascular resistance drops precipitously to adult levels where it stays constant for the remainder of life. And just want to go over some of the normal pressures that we find within the different chambers of the heart and the pulmonary artery. So remember that your right atrial mean pressure is about 4 to 6 millimeters of mercury. Ventricular pressure is 20 systolic over 0 to 5 millimeters of mercury for your end diastolic pressure. And then your mean pulmonary artery pressure is 14 plus or minus 3 millimeters of mercury. In the cath lab, we're able to do what's called a wedge pressure, where we take a balloon and drop it down one of the pulmonary arteries and wedge a balloon in there, and that gives us a pressure of 6 to 12 millimeters of mercury, which should correlate with what the left atrial pressure is, the direct measurement there. Again, 6 to 12 millimeters of mercury. And left ventricular pressure is going to be 100 over 6 to 12. So RV pressure is going to be about 1/5 of what it is in the LV. But mean pulmonary artery pressure essentially stays unchanged. And where pulmonary vascular development comes into play, especially in children as they're developing, it has a very important role within the development of the whole lung. So when there are problems with pulmonary vascular disease, you also can have pulmonary parenchymal disease from that. And that's because angiogenesis, when it happens normally, is a crucial part in developing the alveoli and the distal airspace, and also helps to maintain the lung structure. And helps with metabolism within the lung, and of course doing the end organ function of the lung with gas exchange. So what is pulmonary hypertension? The definition is pretty controversial in pediatrics, although it's pretty widely accepted that the mean pulmonary artery pressure and pulmonary arterial hypertension is greater than or equal to 25 millimeters of mercury in patients that are aged greater than 3 months. And this kind of matches what the adults use, but there's some other caveats that we take away in pediatrics, and that's that the wedge pressure is less than or equal to 15 millimeters of mercury, and there's a measurement that we're able to calculate that I'll show you a little bit more information on later in the presentation about pulmonary vascular resistance, or PVR, and that is indexed to body surface area. If you have PVRI greater than 3 Woods units times meter squared, then that's consistent with pulmonary hypertension. And then for those with single ventricle physiology or palliated with cavopulmonary anastomoses, like a Glenn procedure, Fontan procedure, they have a transpulmonary gradient greater than 6 millimeters of mercury and pulmonary vascular resistance indexed greater than 3 Woods units. And one thing to keep in mind is you have primary pulmonary hypertension, and pulmonary arterial hypertension, so high pressures exist principally in the pulmonary arteries. Then you can have secondary pulmonary hypertension that results as a back pressure from higher pressures on the left side of the heart back into the pulmonary arteries. And so this diagram here shows a cross-section of what the pulmonary arterioles look like. You have 4 different layers consisting of a adventitia, smooth muscle layer, and the adventitia, and then the lumen there in the center. And when there's injury that occurs to this through a variety of different mechanisms, you get dysfunction at all 3 levels here that end up causing proliferation of these levels and gradual reduction of the cross-sectional area of the lumen of the pulmonary arterioles and increasing your pulmonary vascular resistance. And so this resistance is exquisitely sensitive to things such as pH. So those that are acidotic, you can increase your pulmonary vascular resistance quite readily. Hypoxia, and on the flip side, hyperoxia. So if you're hypoxic, that increases your pulmonary vascular resistance. Lung volumes, certainly being closer to functional reserve capacity is going to lower your pulmonary vascular resistance. And there's a component of sympathetic innervation. So things like agitation and whatnot tends to play a big role in how pulmonary vascular resistance is, especially in the sickest of the patients, where you can end up with more pulmonary vascular resistance. And so with pulmonary hypertension, you can end up into a pretty vicious cycle with starting with high blood pressures within the pulmonary artery that leads to an increase in your volume in your right ventricle and decreased compliance and diastolic dysfunction. And over time, as this progresses, you can end up gradually shifting the interventricular septum over to where it'll compress the left ventricle. And as a result, your stroke volume drops, and you can end up with diminished cardiac output, and then get into a process that a lot of times that we see is called pulmonary hypertensive crisis, where you end up with right ventricular failure and ischemia, and eventually death ensues. And this is really important, I think, to understand kind of the progression of things, and as it plays a role within what we call a pulmonary hypertensive crisis, because that term tends to get thrown around pretty easily. And I think there's some specific steps that lead to ultimately cardiac output and low perfusion in that process. And just to review a little bit of epidemiology, it's a pretty rare disease. We're talking about 5 cases per million around the world for an incidence. And the prevalence, depending on what country you're looking at from the various different databases out there, it's about 2 to 16 per million. And the special thing about pediatric pulmonary hypertension is that it's highly variable in terms of its etiologies, more so than in adults. Adults tend to have more idiopathic pulmonary hypertension and hypertension caused by connective tissue disease, and especially left heart disease, with ischemic cardiomyopathy being so prevalent. So just wanted to show you a little bit of the natural history of pulmonary hypertension. This is a diagram that comes from 1991. Dr. Robin Barst was part of this group that published this paper showing the Kaplan-Meier survival curve of untreated pulmonary hypertension. You can see it's rapidly fatal. And this was before we had really good treatments that we now have today. You can see by 2 years after being diagnosed that the mortality is around 50%, and then by 5 years there's further attrition of about another 15% of patients. So it's a pretty fatal disease. Just wanted to show this here. It's a pretty busy slide, but this is to show all the different types of mechanisms that can lead to pulmonary hypertension. It kind of provides the conceptual framework of forming a diagnosis and better understanding the process of pulmonary hypertension among the different patients who come with a variety of different issues. With either primary pulmonary hypertension, which I will mainly focus on this group 1 here, pulmonary arterial hypertension, which takes the lion's share of the prevalence there, and then all the other types of diseases that can lead to it. And just wanted to show a little bit about the different causes of pulmonary arterial hypertension. We could see this stands for idiopathic pulmonary arterial hypertension is almost half of the patients, and then associated pulmonary arterial hypertension that's related to different diseases out there that we know can lead to pulmonary hypertension. That's about another half. The rest of them are going to be more of pulmonary veno-occlusive disease, which is a very, very small minority. And so out of this segment here, this 51% who have an associated pulmonary hypertension, and it's not pulling up. Sorry. well, that's not pulling up, but it goes on to show that the majority of the patients, almost half of them, have a connective tissue disorder, and about 25% of them will have congenital heart disease. And so that forms the lion's share of our patients with an associated type of pulmonary hypertension. And so just to keep in mind, when you do see patients that present with any of these symptoms here, that the history is extremely important in this disease, in being able to make a diagnosis quickly, and to do different diagnostic testing as quickly as possible. Patients that present with exertional fatigue, progressive dyspnea, they present with chest pain, they may have hemoptysis. Syncope is an important symptom that you may find in some of the patients. Cyanosis that can be progressively progressive, and other types of symptoms that tend to go along with heart failure. These are all very similar, but end up with failure to thrive and edema. And things to consider in the past medical history would be, of course, prematurity, if they have any sort of lung disease, and congenital heart disease, if they have chronic thromboemboli that could end up gradually causing damage to the pulmonary vasculature. Liver disease is an important cause of pulmonary hypertension as it pertains to portal hypertension, causing pulmonary hypertension. And then autoimmune disease takes a large portion of our patients. This is a chart that shows a functional class. Think of this as kind of like the New York Heart Association functional class for heart failure. You have 4 different classes that essentially talk about how limiting their symptoms are, from grade 1 being not having limitation of physical activity to grade 4 with those that are unable to carry out any physical activities without being symptomatic. So being able to categorize just how severe their symptoms are. Things to look for in the physical exam would be jugular venous distension from high central venous pressures that result from congestion of pressure and volume back from the pulmonary arteries. You could palpate a right ventricular heave. There may be several present, usually tricuspid regurgitation and pulmonary insufficiency. So a systolic and then a diastolic murmur, and also listening for murmurs of shunts. Paying attention to their work of breathing, and if there's presence of hepatosplenomegaly and edema. And just to review some of the diagnoses that we use, diagnostic modalities that we use within pulmonary hypertension, I've broken this schematic down into 3 different parts. So this first one here, you suspect that there's pulmonary hypertension. It's recommended that the first line of diagnostics that you use are, the typical ones for patients who present with symptoms like this, like EKG, chest X-ray, echocardiogram. And so this is a chest X-ray of a patient with idiopathic pulmonary arterial hypertension. And you can see here, the lung fields can either have oligemia if it's purely pulmonary arterial hypertension, or pulmonary edema if you have excited pressures causing a post-capillary pulmonary hypertension, say somebody who has mitral stenosis or some other type of left heart disease. You see that there's enlargement of the right heart, so you can see a pretty prominent right atrial border, right ventricular border there. And then prominence of the pulmonary artery as well, from enlargement of the pulmonary artery. And then not present in this X-ray, it's important to look for left atrial enlargement as well. You can make a diagnosis of this, of left atrial hypertension off of a chest X-ray with seeing splaying of the left mainstem bronchus, as it doesn't have quite has a more acute takeoff angle from the trachea, and also cardiomegaly. Here's an EKG of a patient with idiopathic pulmonary arterial hypertension as well. And you could see there the tall peaked P waves. That's right about 3 millivolts in terms of its voltage, and that's consistent with right atrial enlargement. There's also right axis deviation. You can see deep S waves there in bipolar lead 1 and a positive deflection in AVF. And then in the precordial leads, you could see what's consistent with right ventricular hypertrophy and usually a strain pattern where you have an abnormality of the QRS T axis. And here you have a pure QR pattern to lead 1, which is consistent with RVH. And just going to play through the echocardiogram here. I'm going to light all these things up. So this is a echocardiogram on a kid with severe pulmonary hypertension in the setting of chronic lung disease of prematurity. And he actually has suprasystemic right ventricular pressures. And so things that you can see from echo from this particular image, it's a parasternal short axis looking at the right ventricle here that's more anterior and the left ventricle, which is posterior. And you can see things like the right ventricular function, which may be depressed. You can see how thick the right ventricle free wall is right here. That anterior wall is about as thick, if not more thick, than your posterior wall of your left ventricle back here. So consistent with right ventricular hypertrophy. The right ventricle is enlarged. It's quite a bit bigger than your left ventricle. You also see septal flattening, varying degrees of it. And I remember I was talking a little bit about septal shift and what that does. Cardiac output, you can actually end up with bowing of the interventricular septum into the left ventricle, which will diminish your stroke volume over time and compromise cardiac output. Other things that we look for that are important on echocardiogram would be tricuspid valve reduction. From there, we're able to estimate pressures using the modified Bernoulli equation, which gives us gradients, and we take some basic assumptions for what the mean right atrial pressure is, which would be added to whatever gradient is that we calculate off this. We also look at pulmonary insufficiency as well, which can, in a very similar fashion, give us an idea of about what mean and diastolic pressures are in the pulmonary arteries. And the other important thing to identify on echocardiogram, since so many of our children have congenital heart disease and pulmonary hypertension, for that is the existence of any shunt that might be present. So moving on with this algorithm, we then focus more on pulmonary types of diagnostic modalities, specifically looking at pulmonary function tests. We do a 6-minute walk test as well. 6-minute walk test is pretty important, especially prognostically, because it's something that can be reliably followed from one follow-up visit to the next as you're modifying treatment, and has a pretty high prognostic capability as well. We also do cardiopulmonary stress tests just to see how limited patients are in terms of physical activity. And then sleep study is extremely important because there is pulmonary hypertension that is related to obstructive sleep apnea. And getting a variety of other different types of imaging, especially to look at the lung parenchyma and getting a high-resolution chest CT, doing that with angiography to sort of pulmonary vein stenosis, which can be a very important cause of pulmonary hypertension, especially in our premature infants. Also using cardiac MRI, which can help us better understand flows and function, particularly as it pertains to the right ventricle. Doing a ventilation perfusion scan, which can help us make the diagnosis of a condition called chronic thromboembolic pulmonary hypertension, where you end up with chronic thromboemboli within the pulmonary arterioles, causing injury and worsening pulmonary hypertension. Obtaining a liver ultrasound to rule out GI causes of portal hypertension. And also doing an echocardiogram with contrast, or otherwise known as a bubble study, to look for occult shunts that might be there. And that moves us down to the last part of the algorithm, which is cardiac catheterization. And this is probably the most important test that we do in pulmonary hypertension. It's actually considered the gold standard for diagnosing pulmonary hypertension because we're able to directly measure the pressures within the different blood vessels and chambers leading into and out of the heart. And one of the most important things that we get here is what's called acute vasoreactivity testing. And so what we're able to do is gradually add on different pulmonary vasodilators to make measurements of what the pulmonary vascular resistance is. Again, I'll show you the calculation for that and why that's so important here in just a couple of minutes. But we usually will start with getting baseline data within the cath lab to see exactly where the patient is prior to starting this, and then we will add 100% FiO2. You know, the oxygen is a powerful pulmonary vasodilator, and inhaled nitric oxide as well. Here we typically do about 40 parts per million. Some centers go all the way up to 80, but there's really no data to show that 80 is better than 40. And oftentimes we will add on an inhaled prostacyclin analog, such as iloprost, which is a medication I'll describe a little bit later, to really bring the pulmonary vascular resistance down as much as possible to see if they respond to any of this. And the response is based on criteria that Dr. Robin Barst, who is a prominent physician within the field of pulmonary hypertension, that she created. And she found that a 20% reduction in mean pulmonary artery pressure, if you have improved pulmonary vascular resistance to systemic vascular resistance ratio with an unchanged cardiac index, that means that you're considered a responder. And what we know from responders is that they are the ones that are most likely to benefit from a calcium channel blocker as a first-line agent for pulmonary hypertension. And so just to show some differences here with pulmonary arterial hypertension of measurements that we obtained on a patient with idiopathic pulmonary arterial hypertension here a few years ago, had a mean right atrial pressure of 20, which is about 4 times higher than what it should be, and a right ventricular pressure that was systemic, so 100 millimeters of mercury, both in the RV and the LV. Mean pulmonary artery pressure was 65 millimeters of mercury, so extremely high, 40 millimeters of mercury higher than what is the threshold for pH. And then we did a capillary wedge pressure that measured 10. And you see that corresponds to what your end diastolic pressure is over here. And so that reflects left atrial pressure as well. And contrast that with a patient who has kind of similar pressures here. There's systemic pressures on the right side, same mean pulmonary artery pressure here, and wedge pressure was a lot higher that we had of 25. So that fits into the category of having post-capillary pulmonary hypertension or pulmonary venous hypertension. And you can see that's probably a result of this high end diastolic pressure, so kind of restrictive physiology down here in the left ventricle. 25, it's quite a bit higher than what you normally see. And so this pulmonary vascular resistance that I've mentioned before is a calculation using what's known as the transpulmonary gradient, which is your mean pulmonary artery pressure minus your mean pulmonary capillary wedge pressure. And that's normally about 6 to 12 millimeters of mercury, as I mentioned. And then dividing that by the cardiac output. And you get the cardiac output either through the Fick equation or through thermodilution in the cath lab, and come up with a number hopefully ranging 0.3 to 1.6 Woods units, which is millimeters of mercury times minute per liter. And that's the normal range there. So there's a caveat to calculating pulmonary vascular resistance in children, and you'll see this on the cath reports, and I used the term pulmonary vascular index earlier. If you were to take an adult and measure their mean pulmonary artery pressure, it'd be about 15 millimeters of mercury. The capillary wedge would be 10. Cardiac output, normal is right around 5 liters per minute. using the formula that I just showed you, the transpulmonary gradient is going to be 15 minus 10, or 5, divided by the cardiac output, which is 5. So you'd get a PVR of 1 Woods unit, which is normal. In children, if you took those same numbers, 15 in the pulmonary artery, 10 in the capillary wedge, and then a more normal cardiac output for a child would be like half a liter per minute. You're going to end up with a transpulmonary gradient of 10 divided by your cardiac output of 0.5. So your cardiac output would be 10. That's not fair. That's a little too high. So what we do is we index that. So adults, typical adult is going to be about 2 meters squared in terms of body surface area, and a child will be about a tenth of that. So just taking the same numbers that we have here, we measure a cardiac index. You can see there, cardiac index is your cardiac output divided by your body surface area, so 5 over 2, 2.5 liters per minute per meter squared in both the adult and the child. And you see pulmonary vascular resistance indexed in the adult, transpulmonary gradient of 5 with cardiac index of 2.5 gives you 2 index Woods units, which is normal. And then pulmonary vascular resistance index in the child is the same. You end up with a transpulmonary gradient of 10 with your cardiac index being 2.5 as well. So your pulmonary vascular resistance ends up being equal. And so why is pulmonary vascular resistance important? So this provides a baseline to help assess whether or not what we're doing is actually working with pulmonary vasodilators and seeing how fast the disease is progressing. And it's really important when it comes to prognosis, because if you're dealing with somebody who has an exceedingly high pulmonary vascular resistance, then they're at very high risk of death. And we're talking about pulmonary vascular index ranges above like 25 as a determinant of risk. And we're going to talk a little bit about the different treatments out there. And this is all based on biochemical pathways at the level of the endothelium of the pulmonary arterioles. And we've identified 3 different pathways that are targeted for pulmonary vasodilatation. And those pathways are the nitric oxide, soluble guanylyl cyclase, and cyclic GMP pathway, the prostacyclin pathway, and the endothelin-1 pathway. And we know from the first 2 that when those are activated, we end up with vasodilatation and decreased proliferation of those 3 layers of the pulmonary arterial, the intima, smooth muscle, and adventitia. We know that endothelin-1, when that pathway is activated, you actually end up with opposite. You end up with vasoconstriction and increased proliferation of those 3 layers, leading to increased pulmonary vascular resistance. And so just to look at the first 2, we'll talk a little bit about the therapies that we use for the nitric oxide pathway. That traditionally includes inhaled nitric oxide. And the one that we've been using for a long time that you're more familiar with is sildenafil. Sildenafil works as a phosphodiesterase inhibitor. It's been used for a long time within adults with pulmonary hypertension. It's actually FDA approved for them. As long as we've been using it in children, it's still not approved by the FDA because of concerns about high doses leading to increased risk for mortality. Regardless, we still use it pretty commonly, especially in the NICU. It's usually a first-line agent for a number of different causes of pulmonary hypertension. And one of the new ones you might not be so familiar with is riociguat, otherwise known as Adempas. You may have seen some of the commercials about this particular drug, but it was the first oral medication as an alternative to sildenafil that can work on this pathway. And it specifically works to help with the soluble guanylyl cyclase pathway. And again, in hopes of vasodilating and decreasing proliferation. So this idea of remodeling of the pulmonary vasculature. And from a prostacyclin pathway, we have a number of different agents that are used, either inhaled or IV form. The epoprostenol, otherwise known as Flolan, is inhaled. It has a very short half-life, so it's not something that's used really outside of an intensive care setting. Treprostinil, otherwise known as Remodulin, is offered in an IV form that is continuously given through a pump, and is also offered through a subcutaneous route, which is becoming a more accepted way, not having to have a central line. Iloprost or Ventavis is an inhaled version. I mentioned that sometimes we use this medication in the cath lab as part of acute vasoreactivity testing, and it's something that's given several times a day, usually about 6 to 9 times a day, so pretty onerous to use. The newest member of this group is Selexipag, or Uptravi is the brand name, used primarily in adults. This was the first oral version of a prostacyclin analog, and it's showing pretty good results. And obviously having an oral route, it's nice to be able to use this instead of inhalational IV or sub-Q administration. They also have less side effects from it when it pertains to the GI side effects. There's currently a trial that's going on with pediatric patients with this. So hopefully within the next 2 to 3 years, we'll have some initial information from that trial. As of now, it's a compassionate use only medication within pediatrics. And then moving on to the endothelin-1 pathway. Again, remember, it causes vasoconstriction and further proliferation of those endothelial layers within the arterial. And the 2 main medications that are used are bosentan and macitentan. These are endothelin receptor antagonists. What they actually do is block the endothelin pathway so that you end up with the opposite effect, vasodilatation and decreased proliferation. Bosentan is currently the only FDA-approved medication for pulmonary hypertension in pediatrics. It got approval here a couple of years ago. There's another one that's kind of a modified form of bosentan called macitentan that avoids a lot of the side effects that bosentan causes, particularly hepatotoxicity. That currently is under trial within pediatrics, and hopefully within the next couple of years we'll hear about the results from that one as well. So there are steps that we can take for patients who are not responding to their pulmonary vasodilator therapy to at least palliate from their symptoms, because they ultimately will end up with right ventricular failure. And some of these are done either in the cath lab or in the OR, but we kind of take a step way back in terms of what we're using interventionally. And in these patients, we're actually able to create an atrial level communication, so doing an atrial septostomy, kind of along the lines of like a Rashkin procedure, but not with a balloon, and then stenting that fenestration that we created, and that can help offload the right ventricle, provide a pop-off valve in case of an emergency. Where pulmonary vascular resistance increases greatly, and you can avoid RV failure. And there is a case report out there of somebody doing the same thing down in the ventricle and creating a fenestration that was stented down, essentially creating a VSD for a patient, and that was successful. Things that we can do, also taking a step way back in the past in terms of techniques. But there are some centers that will do a POTS shunt, which is a connection between the RPA and the ascending aorta, creating a hole there surgically to offload the pulmonary artery so that you have a right to left shunt there. And even some centers have entertained doing the Waterston Cooley shunt, which is on the other side of the left pulmonary artery to descending aorta. And ultimately, patients may need to undergo evaluation for bilateral lung transplantation. And that is a an increasingly accepted form of palliation for these patients, with a lot of improvements over the past 10 years in terms of morbidity and mortality with a certain subset of patients with pulmonary hypertension, currently only done at a handful of centers across the country. And so just to look a little bit at the clinical follow-up that I typically consider for pulmonary arterial hypertension, tend to follow these patients pretty frequently, just as I would for patients with heart failure. And this kind of goes along with current guidelines, seeing these patients about once every 3 to 12 months, depending on their severity. And then following NT-proBNP, which is a hormone that's produced by the heart in response to pressure and volume overload. In this particular one, metabolized, so you can follow it serially within hours if needed. But when it's stable or in the normal range, it definitely has a prognostic value there. Following liver function and renal function tests through a metabolic panel, following CBC for platelets and hemoglobin to look for anemia and thrombocytosis in patients that have coagulopathies or this CTEPH, the chronic thromboembolic pulmonary hypertension type of pulmonary hypertension, along with coags as well. One of the more important screening tools is the echocardiogram, and we'll get that pretty often in those patients to see how the right ventricle is doing, along with chest X-ray and EKG. And as I mentioned before, the 6-minute walk distance test is something that's going to help determine whether or not they're responding to their therapy, because that's going to look at their tolerance of physical activity and just even the most physical activity and pulmonary function tests. Catheterization is something that we need to do fairly frequently, especially when we're titrating medications to evaluate that pulmonary vascular resistance response. And so most of them will have it at least yearly, but sometimes we need to go a little more frequently. And so a little bit about the prognosis. Remember this graph that I showed you earlier showing back in the late 80s, early 90s that survival historically was very poor in these patients with a 5-year survival below 40%. And contrast that now from about 2000 to 2010, there was a group from multiple centers across the world that their pooled data shows that the cumulative survival of patients with pulmonary hypertension is greatly improved. And you can see here that the survival, even just 2 years out, is about 90%, contrasted to about 50% without treatment. However, it's still have pretty poor outcomes overall. When you're talking about 10 years out, you're still at a survival rate of only about 60%. So pretty fatal disease. So one thing that we've learned about the different modalities of pulmonary vasodilators that we have is that when we add more therapy, that more is better. And this is a Kaplan-Meier survival curve from that same paper looking at survival based on the types of therapy that was out there. So if you had those that were those responders that were to acute vasoreactivity testing that could only just take calcium channel blockers, they tended to do the best, so pretty good survival. And those that didn't have any medication, of course, this is that curve that was there previously that I showed earlier. And then monotherapy versus dual and triple therapy has a worse survival. So there's this thought that you should add on more medications as you're progressing if you're not getting the response that you should be getting. And even some folks around the PH community that are advocating for starting dual therapy right off the bat, or sometimes even triple therapy, depending on how severe things are, because survival is improved. So in summary, Pulmonary arterial hypertension is an exceedingly rare disease, but again, you're in a quaternary center, so you're going to see it from time to time here, patients that are admitted. We do have a variety of different non-invasive testings that we use as kind of first line to identify this disease. Catheterization is the gold standard and really aiming at trying to get the pulmonary vascular resistance number to help us with prognosis. We have better treatment strategies now, but nothing is really protocolized. There are very few guidelines, very few randomized controlled trials out there to help us decide what's the best way. It makes it really difficult when you're dealing with a disease that's so variable clinically in the way that it presents and the etiologies that it's just really tough to come up with specific strategies. So sometimes we take in lack of a better terms, kind of a scorched earth approach with some of the treatment and, one size fits all. The outcome is still fairly poor, but improving over time, and hopefully with the addition of some of these other therapies that they're using in adults, hopefully we will have improved outcomes there. I did want to just put in a plug, something that I'm doing here, and in conjunction with many of you here at the hospital, and that's the creation of a pulmonary vascular disease team, really taking a multidisciplinary approach to caring for these patients because they're so complex. They have so many other issues going on besides the pulmonary hypertension in terms of other, their primary disease that may be leading to that. And so we've already had a meeting to discuss kind of the initial goals and what we're looking to accomplish, but we're looking for dedicated multidisciplinary team members that can serve as go-tos for patients that are typically seen within their subspecialty who may have pulmonary hypertension. Looking at the possibility somewhere down the line, and this is probably years down the line, but creating a dedicated multidisciplinary outpatient clinic. This is a model that a number of the larger pulmonary hypertension centers have, like Stanford and Texas Children's Hospital, Washington University. And establishing a regular presence on the different units to round on these patients. So, forming an inpatient consult service, and then also doing case discussions so that we can learn from our patients a little more, meet together perhaps once every couple of months or so. And then devising consensus on management. Since it's highly variable what other centers do, I think it would be helpful for us to put our heads together and come up with an agreed upon approach for a lot of these patients, because there sometimes can be differences of opinion quite often. So the last thing that I'm to work towards getting is a certain designation from the Pulmonary Hypertension Association, which is a not-for-profit organization here in the U.S. That gives a care center designation for centers that meet a certain number of criteria. I'll discuss that here in a second. But these are the proposed subspecialties that I think should be involved based on the etiology of a lot of the associated pulmonary hypertension. Of course, our intensivists in the NICU and the PICU, pulmonologists, members of the PAC team, those from surgery especially plays a huge role in our congenital diaphragmatic hernia patients, genetics, pharmacy as it pertains to the various pulmonary vasodilators and anesthesiology, extremely important for the patients undergoing surgical procedures that need general anesthesia and managing their pulmonary vascular resistance with a variety of different agents. So this is the care center accreditation that I was just talking about, again from this organization called the Pulmonary Hypertension Association. And it really is aiming to improve access to care, to improve quality in doing outcomes-based research, having a database that's available for other types of research known as the Pulmonary Hypertension Association Registry, and also standardizing care around the country so that we're all kind of on the same page and that patients are getting consistency in terms of their management. And that's it. guys have any questions?
I apologize if you talked about that. Thank you very much. That was great. I always remember how many things I have forgotten when I hear talk like this. If you covered this and I missed it, I apologize. But could you talk a little bit about obstructive sleep apnea and sleep problems and how they may or may not relate to pulmonary hypertension?
Yeah, so with obstructive sleep apnea, you get increases in introthoracic pressure from having the obstruction high up in the airway, and this kind of caudal progression of fluid in the heart, and the chronic hypercarbia and hypoxia that occurs, and the changes that happen because of that on a vascular level can end up leading to proliferation of the arterioles and leading to increased pulmonary vascular resistance. So chronically over time, it's something that can happen in a number of patients. And if somebody does have pulmonary hypertension from obstructive sleep apnea, it's obviously very important to identify that because it's something that's potentially reversible with a tonsillectomy, adenoidectomy, and non-invasive ventilation maneuvers. Thank you. Yes?
You didn't mention fluid overload as a cause of pulmonary hypertension, and I bring it up because in newborns for decades we've used diazoxide like water for hyperinsulinism, and it's only recently this concern has come out about fatal pulmonary hypertension, and so we give diazoxide with diuryl, and I've just assumed it was fluid overload, but is there more to that?
To what? Sorry, I didn't hear the type of condition, the specific
hyperinsulinism.
Oh, with hyperinsulinism. I don't know specifically as it relates to hyperinsulinism what the pathway would be from that, unless it.
Well, it would be the drug diazoxide.
Oh,
and supposedly just by giving diuryl that takes care of that problem. So I've just assumed it was fluid overload.
Yeah, I mean that's certainly a plausible reason for that. I don't know specifically about that medication and how that can change the pulmonary vascular resistance, but fluid overload, if it's creating such a large amount of intravascular volume, it could mimic over time what happens with other types of intracardiac shunts and retaining fluid, that pulmonary overcirculation or concept of pulmonary overcirculation with congenital heart disease. But I haven't learned about the other mechanisms regarding that specific medication. Yes.
Hi. Each of us in turn is finding things that we can relate to in this very complex set of mathematical and stuff like that. A little over our heads sometimes. But when you say connective tissue disease, that's a pretty vague description. And could you be more specific about what you mean about connective tissue disease and which ones might be subject to this issue?
Okay, so I think looking at a lot of the autoimmune conditions, things like lupus, systemic sclerosis, scleroderma, that sort of thing, those tend to be the more common causes within kind of a connective tissue disease.
So more acquired?
Acquired, yes.
Thanks, Dr. Rodgers. Great talk. Could you speak about the use of pediatric lung assist devices in this population as either a bridge to lung transplant or as a durable therapy, and any recent advances in using that?
I don't know a whole lot other than that there are certain centers, very few centers, that use certain types of oxygenators that are kind of a lung replacement therapy in these patients. Even ventricular assist devices to some extent, if you were to place an assist device over on the right side. So I really don't know the advances pertaining to that. It's pretty sparse in terms of the number of centers using that. It's certainly something that I'd like to learn about, though.
So, one more question here. So you mentioned possible lung transplantation as a treatment, okay? Is there any data about that and what the expectation might be for
young child who has a bilateral lung transplant in terms of survival of the transplant in this group of patients?
Mm-hmm. No, there is. I'd actually heard a great talk on this at a recent symposium on pulmonary hypertension out in San Francisco from a group at Nationwide Nationwide Children's Hospital, talking about how things have improved with lung transplantation. The survival from it still remains kind of bleak, but is approaching 5-year survival rates that are similar to that we see in other types of transplantation. Maybe not quite as good as heart transplantation, but there's still an incredible amount of risk in terms of infection, especially within the first year, leading to demise. I do have some articles and some graphs like Kaplan-Meier survival curves. I didn't include it on this because I thought it was a little bit out of the scope, but I can certainly show you what's current out there in terms of advances in survival of those patients.
Are there common genetic causes of pulmonary hypertension that we see in kids?
Absolutely, and so that's a whole talk in and of itself, but there are a number of identified genes associated with pulmonary hypertension, the most common being the BMPR2 gene and mutations that are in that. It's part of the TGF beta signaling pathway that can lead to proliferation of the different layers there within the arterioles. CAV1, SMAD, different transcription factors within the cell that are all affected by various different types of mutations. And there's a growing body of evidence that a lot of these patients, even though they may not have a specific genetic mutation to like a familial pulmonary arterial hypertension, such as those with BMPR2 mutations, but if they have certain changes within the DNA, their genes with specific BMPR2 genes, that it may make them more apt to have pulmonary hypertension and maybe have a different course than other patients who don't.
So that incidence of 0.5 per million, which seems pretty low, is that for primary pulmonary hypertension or idiopathic pulmonary hypertension? Because it seems to me that around in the field, that not only in cardiology, just walking around the hospital, we see many more patients with pulmonary hypertension with associated conditions. Mm-hmm. So is that a different number, I assume?
Yes, it is. So for primary pulmonary hypertension, like idiopathic pulmonary arterial hypertension, that's going to be the incidence for that. That's where we have the most recent data on. But no, you're absolutely right, especially when you're looking at associated conditions and the growing population of patients with congenital heart disease that are living a lot later, especially single ventricles. That number is increasing. Yeah. Anyone else? Thank you.
You have been disconnected from the meeting.